welcome to the second Baltic Sea regional seminar. We haven't discussed who would chair this or moderate this symposium, but if it's okay with all of you, I will try to keep us together. Thank you, Bosina, you're nodding. I think we should start with a quick presentation, just who we are and what country or organization we represent. And I can start where I see the pictures in my screen. So I will start with you, Margareta, please.
Margareta Kristensson, colleague to Ralph, and from Sweden, and former HPH coordinator, and I shall speak soon.
Welcome. Börje, welcome.
Thank you. And yes, Börje Bjelke, Professor in Geriatrics in Norway and Chairman of Eugenia Foundation and the Seniorvärlden in Sweden. We're very happy to be with you.
You're most welcome. And Nan.
Yeah. Hello, everybody. I'm a coordinator from Denmark, working with Hanne Tønnesen, as you know, most of you, I think. And yeah, we are only very few sites here in Denmark now, but we hope we'll become more eventually. Yeah.
Okay, you're welcome. We hope so too. We will do our best to help if we can. Bosina, welcome.
Hello, everybody. I'm Bożena Walewska-Zielecka, national coordinator from Poland. I'm a university teacher in public health department on health sciences faculty in Warsaw Medical University, and last but not least, I'm the chair of HPH organization. Thank you very much.
We're proud to have you with us. Thank you.
Yeah.
Helena, welcome. We are doing a short presentation, just who we are and what organization we represent.
There we go. There I go. Thank you very much. I'm sorry if I was late. I am Helena Holmgren. I'm from the Stockholm region. I work with public health issues at the Public Health Department of the region of Stockholm, and I'm also head of the unit of the national, one can say HPH, which is called HFS in Swedish.
You see it in my background. Thank you. Hans, welcome.
Hello. I was late to the meeting, but here I am. My name is Hans Brandström. I'm a general practitioner on the island of Gotland, in the middle of the Baltic Sea, and I'm also in charge the medical. In charge for the medical part of the primary care on this island, and I'm also part of the national committee of our common organization. Yeah.
Okay, and you're welcome, and you're just in the center of this seminar in the Baltic Sea. Eva, we don't see your picture. Maybe you don't have a camera, or would you like to turn it on? I can see Eva.
Sorry. Yeah. Do you see me now?
Yes, definitely.
I think from safety reasons, Zoom has been blocked in our organization. So I have joined via my own mobile phone to the meeting.
Okay.
But I can hear you all very well. I am a coordinator of health promotion and well-being at the South Savo Social and Healthcare Authority in Eastern Finland. hello everyone, and nice to meet you all.
Good to see you too as well. And I can just say that if you would like to try on your computer, there is another link to enter this. It's through Zoom, through Skype or Teams. Maybe you can get in. But if you're with us, so it works fine.
I think this work rather
Good.
fine. So I think this is good
Okay.
to see you. Yeah. Okay.
And we move on to Juha. We see you as well now. Welcome. We have a short presentation. Yes.
Oh, thank you. Good morning, everybody. I'm Juha Ahonen, and the chair of the Health Promoting Hospitals and Organizations here in Finland. And I work as a coordination manager in the Tampere University Hospital. And there I work in Department of Psychiatry. Very nice to meet you all.
Same. You're most welcome. And then we have Trine. Trine, if you are with us. We don't see you and your microphone is muted. No, I'm not sure we have a connection. How about Auli?
Hello, I'm Auli Pölönen from Tampere University Hospital, like Juha. I'm a coordinator manager as well. And my field is about more internal medicine. And my background is nutritionist and dietitian. So I'm interested especially in nutrition, quality improvement of nutrition care, and I've been working quite along with this health promotion issues and well-being as well.
Wonderful. Good to have you with us. And we turn to Oliver.
Yes, hi, good morning. Great to see all of you. I'm Oliver Gröner. I'm from the International Secretariat. I'm very pleased to be with you today and to have some discussions on the use of the standards.
We're happy to have you with us. And I've saved the best for last, the one that is the spider in our web that has arranged this meeting together with us. And Karin, welcome.
Thanks. I think most of you know me already. I'm the coordinator of the International Secretariat. I'm also the coordinator of the German network of health promoting hospitals. Glad to see everyone today.
Good. The only one we didn't get in touch with is Trine. I am trying again. It's like the Eurovision Song Contest, you know? You turn to the different nation. But if you hear us, you can join whenever. Okay. I tried to share the program or the invitation, and here is the program, and we're already a bit into that, so we will let you have your 15 minutes, Margareta, but you have the program, I guess. So without further ado, I think we start with the introduction to this seminar, and let you, Margareta, introduce us to health orientation of health services.
Thank you so much. Jag ska bara se så att help them get the right
Good.
slide. Mamma, teknik.
Det är bara att klicka på starta bildspel från början längst upp till vänster där, tror jag.
Ja, men jag tror jag hade den uppe, tror jag.
För nu ser vi de små bilderna. One minute, 1 second. So thank you very much, everybody. And as you know, I have been working for this with these issues many years, so I will take you back a bit from the start. But again, my name is Margareta Christensson, and I'm professor in social medicine and public health
here in Linköping, past chair in the governance board, and I also was the national coordinator in Sweden for many years. And I wanted to start with this picture because
Margareta, I'm sorry to interrupt you, but we see, or at least I see, your small slides, not the big picture.
konstigt.
And it's the so om du får klicka någonstans på starta bildspel, för det.
Your screen sharing is paused.
Så nu försöker jag en gång till här, får vi se. Nu så, nu är det lätt.
Thank you so much. So, that enough?
It's good.
So this is the main reason for why we are here. I think that we are trying to meet the main challenges of health services. The changes in demography, with more elderly, the changes in panorama with more chronic diseases, the increasing part of healthcare which is repairing, not curing, new demands from users, new demands and technique, and knowledge and technique, and within an increasingly strained economy. And this is the reason why we have increasing demands to develop a more effective and more proactive health service. This is not new. This is exactly the reason why the idea of reorienting health services was one part of the Ottawa Charter, 1986. And what we need to discuss now, what do we mean by reorientation? That is a common question. And this is about reorienting towards health gain. That this is to remind us, everybody, that this is the aim of the service for patients, co-workers, and the public service, the health orientation. And actually, Jürgen also remembers, and maybe Oliver, you remember the discussions we had, whether this is about when it was only hospitals and hospitals and health services. Do we talk about health promoting hospitals or health promotion in hospitals? Because that is a rather big difference. There was one person who said, well, health promoting hospitals is nothing else but an ordinary hospital with a department of health promotion in it. And that is not very effective. And we had the metaphor of sugar on top of the cake. And we need to have sugar in the cake, which makes the cake be good and even growing better. And this is, so the health promotion and disease prevention activities, they are not there for somebody else, for the health of people decades later, but to optimizing effects of health services here and now. And here Helle's research has been so important to demonstrate that this is important the week after the surgery. It's optimizing health services here and now. It is about taking responsibility for our own health personnel, but it's also about supporting public health intervention in the population served, using our knowledge of causes for disease. And for this, the theme of today, we need to use health orientation as a means to become more effective. And we often have talked about the concept as a coin with two sides. One side is reorienting health services to have a more effective organization. But the other side is that the point is that we use the knowledge, the authority, and the context of healthcare with the population to lead to a more effective public health initiatives. And this is a picture which may look complicated, but it's not. Rather, I have the Swedish picture, but I put on the English terms on it. This is the way through health services, written by Bo Burström, which says that if you start at the left, patients who come to the hospitals have rather different packages on them on health determinants. Some have no risk factors, other have rather plenty. Yes. Smoking has a difficult social living situation, etc., and being more or less vulnerable. Having a health state making them need health services. And their needs are then balanced by affordability of health services on the top in the middle, and below that, accessibility to health services. And this defines their demands of health services, and in the next step, their healthcare consumption. As Bo Bursham tends to say, in the best case, people consume the care they need. And in the end, we have a health outcome. And all these errors, they are pointing to the health outcome, and that is health orientation. And this is now much more defined and described in our new definition, that health promoting hospitals and health services orient their governance model, structure, processes, and culture to optimize health gains of patients, staff, and population served, and to support sustainable societies. The focus of health orientation and health outcomes. And this is actually something we have discussed for decades also. At the conference, international conference in Linköping, 1995, the title was Health Gain Measurements as a Tool for Hospital Management and Health Policy. And I remember one fantastic speaker from Scotland who talked about health gain orientation as a way of herding cats, meaning that this gives us the same, we have the same target, the same aim, everybody working towards the same aim, and stop competing, but helping us collaborating. So one reason for health gain orientation is to help us collaborate even better for the same targets, the same aim. But it's also so that we have now this conference also in Paris discussing this, and when the subject come up, actually I was in France in Bologna on the French conference, and they discussed their problems in France, where they said, we do want to work like this, but we can't afford, because if a patient comes to the hospital and doesn't have any medication, or is not coming into the clinic for a bed, we have no pay. We don't have any pay at all if we only give an advice on, for example, alcohol problems. And this is one of the reasons why we need to discuss health orientation and to look at why we are here, because I believe in all the countries around the Baltic Seas, our management is rather much focused on productivity and even paid for productivity. And we even not always measure outcomes. And sometimes people say that we don't need to measure outcomes because we work evidence-based, and that we know that if we have the right processes and products, then we have the best outcomes. But it is not so easy, because that is efficacy. Efficacy is evidence-based intervention based on randomized controlled trials. And everybody who has been close to randomized controlled trials knows that those research objects have to be knowing the language very well. They shall not be allowed to have more than one disease, and not many other complicating situations. So this is the applicable in the ideal situation. Effectiveness is what is working in the routine work. And if we shall try to measure health economic effects, efficiency, that has to be based on effectiveness studies, which is quality assurance work. And then the question is, what kind of outcomes should we use? And I've been struggling in the Swedish network quality registers, where you have about 105 measures of processes and products, and then it's linked to the register for mortality. That is not very interesting if you have a chronic disease, for example, rheumatic arthritis. So we need to have a more holistic health outcome measure. And the WHO definition of health being not only absence of disease or illness and infirmity, but also best possible, we don't have to discuss whether it's complete or not, best possible physical, mental, and social well-being is to me extremely important. And this is possible by using measures such as Eurocall or SF36 to measure health-related quality of life in terms of best possible physical, mental, and social well-being. And this is what we call PROM, patient-reported outcome measures. But we also need to be better on also looking at PREM, patient-reported experience measures. So what I think we need to do is, when we mean by health orientation, that is that the full management, leadership, and organization uses assignments with explicit objective for health promotion and prevention, with outcome and quality assessments, including PROM and PREM. And I think also we need also to use more health economy analysis to have even better arguments for doing the things which we, in one way, know that we shall. And again, the holistic view of health is not only a beautiful thing, but a good health-related quality is also a way of having a better prognosis for somatic disease. And this was the theme of our conference in Gothenburg, towards a more health-oriented health services, an issue of body and mind. And I'm therefore very happy that we now, in the new standards, have these objectives, that the organization is committed to orient governance models, policy structures, and processes and culture to optimize health gains of patient, staff, and population support, and support sustainable societies. And also in one of the some standards, that we systematically monitor needs and determinants of health and population as a basis for planning and evaluation services. The very start of the chain, which we talked about, the health determinants for people, but also that we have information systems that integrate measures required to assess the implementation of the HPH vision, that we do measure whether patients have the more proactive services, but not least that procedures and interventions for improvement of health outcomes are periodically evaluated. And with this, I mean not only mortality, but also health-related quality of life. And this I shall be happy to discuss with you more today. So thank you. This was my end.
Thank you very much, Margareta, for both a beautiful presentation and interesting thoughts to discuss in the group discussion that we will have in a little later in the program, but also for keeping the time exactly 15 minutes. So that's an extra plus to you. And I don't think we will take any discussion now. If it's okay, we'll go into the group discussion a little later. But instead, I will pass the ball over to. That's a good pun now when we have the European Championship. But I will pass the ball over to Oliver to share with us his thoughts and knowledge on the HPH standards and how we can use them and operationalize, that's a difficult word, the health orientation approach for health services. So please, Oliver.
Yes, thank you. Can you see my slides?
Yeah.
Perfect. So yes, thanks also to Margareta for setting such a good ground for the presentation of the standards now. I want to describe a little bit how we develop these standards, how they look like now, and what our plans are at the international level based on the discussions we've had at the last General Assembly. Yeah, okay, that's the outline. The background to the whole process is, as some of you may know, that it seems like a long time ago, but it was just last year in April that the General Assembly recommended to set up an ad hoc working group to develop a process and finalize an overarching standard set. As you may know, we've had various standard sets developed by different working groups and different task forces, and the General Assembly wanted these to be integrated into an overarching standard set or an umbrella standard set. And members of the working group included Antonio Cerenza, Rainer Christ from Austria, Birgit Metzler also from Austria, Margareta, whom you know, Sally Fawkes from Australia, and Karen and I from the Secretariat. What were the components of this process? So first, we had the work conducted by Antonio Cerenza from Italy, which goes back even a few years. And Antonio had done a mapping of the different standards, say for mental health, for children, adolescents, for environmental factors, for health literacy. And while each of these standard sets that were developed within the international network had their own focus area, there were a lot of commonalities. And you might also say a lot of overlap to some extent, because each of the standard set required some level of management responsibility. And it was, from a practical point of view, then difficult to integrate all these different standards on responsibility of management that have been published in different documents for the management to actually take action. So there was a good argument made by Antonio to integrate these standards into an umbrella standard set. So that was the basis of the process. And secondly, we then organized a Delphi panel with 2 stages to review the scope and specific standard statements for the standards. And thirdly, we had various working groups consulting on these standards and refinements, and these the consultations were done very broadly, involving all network coordinators. Basically all attendants of the General Assembly were invited to contribute, and in addition we reached out to various experts that were not represented in the General Assembly, but whom we know had an interest and an experience in this process. Then there were additional steps in the development process, and somewhere it's very small, I'm afraid. It's here on step 4. Some of you may remember, because from the Secretariat perspective in the last year, we used every opportunity to validity test, to check whether the standards are relevant. And we had a meeting with the Baltic networks last year. And at that time, the standards were not finalized yet. And we used this meeting, some of you may remember, to validity test and to actually work through the wording and the implications of these standards. The problem with or the challenge, better said, with the integration of the standards was that if we had just taken all individual standard sets on mental health, on adolescence, on health literacy, on whatever, it would have been 668 standards derived from these documents. But through the Delphi process and through the consultation process, we were able to distill the essence of these standard sets into one document with 5 standards and with well, 5 domains, I should say, and with 86 specific standards. So from 668 to 86, so a huge reduction. It's still a lot, and it's a comprehensive document, but it's much more manageable than if we had just taken the documents and fitted them together with the 668 standards. And we were very lucky that, happy, delighted that at the General Assembly November last year, we were able to present this work, and the General Assembly agreed with these standards to be the guiding document for the network, and that further work should be done to build on this, to develop a self-assessment tool and online tools, and also to think about a process how to keep this document up to date. So what we have done since November last year, well, we had a final feedback round in December. We then worked on the layout and were able to publish the final standards in the first week of January. We then prepared translation templates and conducted some webinars on the standards. And we are very pleased that various translations have been completed or are in progress. So 1, 2, 3, 4, 5, 6, 7, 8, 9 translations that we are aware of at this stage. And the ones marked in green are the ones that are actually already on our website in a final PDF document. And the other ones that are written here as to be in final stages, we hope to be able to put them on the web also very soon, so that we have our standards document as a guiding document in line with the new definition that Margareta showed and in line with the new strategy available in many different languages. We then worked on the measurable elements in May, and you may see, you might have seen this in the document. So we've got the standards, we've got substandards, and then the actual standard statement, what the organization should do. But the question is still open, how to measure that. And for that, we are building a tool. And this spreadsheet has been sent around again to all members in the General Assembly, because I'm very much aware that the Swedish network has already developed a spreadsheet with measurable elements and some beautiful graphs that show level of achievement on the standards. But of course, we couldn't have just taken the Swedish proposal for the international network. We need to see how, in the international context, we can build on the experience that is available in the international network and propose a set of measurable elements that are hopefully applicable to the wider set of networks. There might be then additional adaptations required in the countries, but at least we will have a overarching set of measurable elements. And an example is that in the current document, we have a standard statement, say on 1.1.5, our governing board reviews the implementation of the HPH vision. That's a statement. And how it can be assessed is, well, look at the minutes from the governing board. If the governance board doesn't have an item on the agenda, which says review of the HPH vision, then that might be an indication that it has actually not been discussed at the governance board. You might even go into more nuances if the governance board talks 3 hours about finances and 5 minutes under any other business on the HPH vision. It might give you an indication on how serious the organization engages with it. So that's something that we're going through now at the moment. We have feedback from various countries, and for each of the 86 standards, we will propose a measurable element. The timeline for that is now, we have received feedback. Some networks asked for a bit more time, so we're still waiting. We will be working towards incorporating these comments and send it out for another review. We plan to finalize a self-assessment tool in August and then prepare further standards working tools. And what are these working tools? So first, we will produce a PDF document, which includes the measurable elements. Some of you may remember that the Danish network, or better said, the Collaborator Center in Copenhagen under the leadership of Hanne Tønnesen, produced also a series of documents on the implementation of the standards. And in fact, some of them might be integrated into this new document because they give a good indication on how data can be collected and data can be used for the improvement. So these ideas are not lost and might be integrated there. Secondly, we will produce an Excel spreadsheet because some networks might want to build a data collection tool based on this spreadsheet. So this is very conservative, I would say, or expected, and will be prepared for the networks. But then we're living in the year 2021, and not only the last 1.5 years, we have worked a lot on the internet using all kinds of tools. It's all we should explore how we can use interactive tools to facilitate the assessment and implementation of standards. And one proposal that we are currently discussing, we have proposed that at the General Assembly, and we will continue the discussions with the Governance Board, is to develop an app or perhaps a web interface. And the question is, what can this app or web interface provide? First, of course, data security. If we collect any information from anyone, we need to make sure that we comply with data security and privacy standards, because you might foresee a situation where a professional in a hospital rates a standard, and the simple question then is, who should be able to see this rating? Only the professional, if it's a sort of a representative blinded assessment of compliance with standard, or should it be the peers? Should it be the manager? Should it be people beyond the hospital? So even with that very simple question, there are concerns about data security and privacy that we need to acknowledge. Secondly, the app or the web platform should provide very easy navigable access to the standards, perhaps even searchable. In the PDF document, you need to go through step by step, and you need to find your way through the document. However, if you were interested, for example, in any standard that is related to food, provision of food, procurement of food, canteen, nutrition, perhaps we need to have a search function where you enter food, and then everything in relation to food comes up. It should further support different levels of users, network, hospital, professional. What is the need of a professional in relation to the standard? What is the need of a hospital manager in relation to the standard? What does the network level want to know about the implementation of the standard? So again, there needs to be discussion about these users, also in line with the first one about privacy. For me, one of the key advantages of living in the online world is that perhaps we can identify models of good practice. Say if 50 hospitals or health services assess their organizations against a standard, and perhaps there are 3 organizations that perform really well because they have worked intensively on this in the past, they might constitute a model of good practice. And wouldn't it be nice if we were able to identify these, provided the members agree? For example, if we stay with a food example, imagine there's a hospital that has solved the issue of healthy procurement of food. It would be very good to be able to identify that and perhaps receive further information on what they've done. We also continue to have our working groups on task forces, which continue to work on health promotion for adolescents, the elderly, on literacy, on mental health, and they generate a lot of resources. It would be easy to integrate that through linkages within the online platform. There are also a lot of external training resources or internal within the network that we could link to or that we could develop. Say if, Margareta's talk this morning could be a training resource linked to Standard 1 on the role of management and health orientation. It could be easily linked. And we have already multiple language versions of the standards through translation. But we know that any user in, say, Germany in a hospital, they would feel much more comfortable using any information in German rather than English or another language. And I assume the same is the case for most countries. So we could embed automatic translation functions. Some of them work really well already to facilitate access to the information. We have, maybe Ralph could say more on that. We have another session, I think sometime after the break later, where I would like to go into more detail of discussing these functionalities with you and to get your feedback on what you believe might be useful for users within the health services which are working towards health orientation. Yeah, and that I think was the question, how can we operationalize the health service orientation approach? This is also our email address. Any ideas, feedback is always welcome. And I think with that, my time is consumed and I give back to Ralph.
Thank you very much, Oliver. Beautiful and interesting. As you pointed out before we started this session, I've already heard this, and Margaret has already heard this, but that I think can be repeated several times. The subject and what you want to point out with these standards. So we will now go into a session of group discussions. And I would like to point out that we will be 4 persons in each group, so we will have time to discuss with each other. And we've heard Margareta address the point of the aim of what we're doing is to optimize health gain through effectiveness rather than productivity, which is an important basic issue. And we've heard Oliver discuss how these new standards may help us to assess whether we are a health-orientated institution or a health-promoting institution. So I would like to ask you to discuss these two issues, but of course you're free to discuss other things as well. And we will have time until 9:30, so we cut it a little. We will have about 15 minutes, 17 minutes, and then we will meet again in the plenary to have a short summary and feedback from you. So please prepare something to share with each other, and then we will go into a most deserving coffee break, I think. So if no one, is there anyone that has a question before I throw you out?
Just a question, do you still see my screen?
Yes.
Yeah, so I need to press here probably, right?
Yes. Good,
Okay.
Now we see you in full size.
Good.
Great. So have a nice discussion then.
wait for the others, I guess. This is the main room.
There. So, okay, everybody is back. I can see we're only 10 left. I know that, and now I forgot her name, from Finland, one of the Finnish delegation has left, I think.
Hans is also busy in 30 minutes from now.
Okay, so they will perhaps come back. Okay, I hope you had good discussions in the group. We certainly did, but we had the benefit of having Oliver with us, but I think you had equally as good discussions. Is there anyone who would like to share your thoughts with the rest of the group? I don't know. I will ask you, Nan. Would you like to start out and just give us some reflections?
Well, our group had a discussion around, well, actually around the standards, the use of our standards, HPH standard in primary care, to access our users, patients, as early as possible, to have this, well, you also can say proactive idea in the standards. So when the patients first come to the hospitals, their disease may be more advanced. So if we can reach our patients, users in primary care early in the disease course, we could gain more health, so to speak.
Good. Yeah. I'll just let the word be free, so feel free to share. Remember, sharing is the best we can, gift we can.
And also Botsena also pointed out the need of a more proactive way of working in terms of primary prevention, reaching out to people before they come to health services, and that is an important part of these standards where this is now explicit. But maybe you, as being in the psychiatry, would you want to say something, because this is also a very special form of vulnerable patient population.
Yes, yes, I'm here.
Yep.
Thank you, Margareta. And I think it's very important to utilize these standards also to the psychiatric patients and to be wider mental health work. And I think here in Finland, we are having big issues and renewal when it comes to social and healthcare organizations. And the primary healthcare is the core of all, and healthcare centers are the most important element of our healthcare system now and in the future. So I think there is good place to implement these standards also in healthcare centers, because here in Finland, it seems to me that the standards and the health promotions is very much an issue of the healthcare districts and specialized nursing care. So I think the standards are very wide, and the concerns of 33 countries, right, Oliver? And so we have to choose very wisely what to implement here in Finland, because not all the standards are, I'm not saying not that important, but we have to choose what we are going to use here in Finland to develop our healthcare systems, and especially health promotion in those settings.
I have a question about that, actually, maybe to you, Juha, and also to Oliver, and to all of us, because we have found the same here in Sweden, that not all of the standards are applicable. We're not, they are equally as important, but they're not applicable in all settings. So we need to exclude some to get focus on others. And what do you say about that, Oliver? Is that kosher, or is it to step out of line?
I think that's, of course, a challenge in any kind of document which serves as a guiding principle internationally. You might argue it always reflects some level of minimum consensus on what should be done, which also means that perhaps consensus requires sometimes a country or network needing to adapt or change a little bit locally. So I think it's perfectly, from my point of view, perfectly acceptable and even desirable if a network looks at these standards and says, well, yeah, that's helpful as a guiding principle, but in some areas we need to adapt it, we need to do something different. So I think that actually shows the engagement with the standards, and it's very, very promising. Also what you said, besides the adaptation, it's perfectly okay to set a smaller target, not to start with addressing everything in the standards, but pick a piece and say we're going to start working on that. It's even written in the document somewhere that we don't expect anyone to go through the whole thing at once and start assessing everything and start improving everything, because resources are always limited, and it's much more useful to pick a point that is locally relevant and start working on that. We also had in our group hourly reporting on the work they've done in relation to nutrition, and I found that very interesting. And if there's one component in the standards that is of particular relevance, start working there. And sometime in the future, in 1 or 2 years, you might add to that. And it's certainly, there's a lot in these standards that could keep us busy for a number of years.
That's great. Yeah, thank you. We have a group here with Eva, Helena, and Kieran. Would you like to share what your discussion concerned? Would you? Yeah, Helena.
Well, I think that we actually had about the same questions that we discussed, that the standards are quite extensive, and we also said that we could probably use it as starting off with one of the blocks kind of, and dig deeper into one. And if you use like the main subjects to identify where we do have the gaps, and then dig into that one where we have identified as this is where we have the gaps or where we need to start off, and then start there. But we also discussed, or Hans, who is not in this meeting right now, but he raised the question if this could be useful as using when starting a discussion, and we said that it is. It is extensive, but it is also good to maybe have as a basis for discussion. It's easy to say that this is what we have from the international network, and we use it in the national network, and these are some questions we want to discuss with you as well, and then bring it up to the management level. In either hospital or in unit or county level or wherever you are. So it's good for using as a basis for discussion, we said.
Great.
Eva, you must fill in here.
Yes, Eva,
and Karin as well.
Okay, I think that when we assess that is some standard applicable or not,
we can. I think we could make teams for assessment several standards, and maybe this could be some kind of quality assessment in organization. Different teams could assess different standards, I think. For example, if there is hospital staff or healthcare staff, and there could different team assess that what kind of improving or gaps we have considering of staff. And for example, standard 1 could be for management team, and they assess, and from different teams, when we put them together, then we can have our organization quality assessment whole, I think.
Very interesting. I put my hand up, but Margareta has also put her hand up. I just want to tell you, if you want to make a comment, you know, you have in the reactions on the bottom, you have something called reactions. If you're using an iPad, I think it's on the top, and you can raise your hand. Just don't forget to lower it when you've had your time in the sun. Margareta, please.
Well, Eva said everything I wanted to say so beautiful. So I do agree, Eva, and there is a point that they are comprehensive, because, and that is also a sort of communication. Just looking at the different domains help us communicate what we mean by health promoting health service. But then we need to have different themes looking at the different parts. And then maybe for the top management to have conferences and to look at the whole map. Where are we good and where do we have to be better? So I do agree. Thank you.
Thank you.
Thank you. And I put my hand up, and I would also like to agree on this. I think it's necessary to form teams. It's not a one-man or one-woman job to assess whether it's on the clinical level or on the hospital level, etc. So, but I think that what we discussed in our group, and also I hear here in this plenary session, is that we need to keep the goal or the aim of all this in our mind. Why are we doing this? It's not to tick off. I think Oliver used that word. It's not just to make, okay, we've done the assessment, check on that, check on that, check on that. It is, do we actually move towards the aim of optimizing health for the patient, for the population, and for the co-workers? And I think in our group, Oliver, together with Auli, showed a beautiful example of how the environmental part of the standards are important to use. I don't know if you would like to, I think if you might want to share that with us, because I thought that was an excellent example of why the standard of how we produce food is actually important. Would you like to share it, or do you want me to? Oliver, yep.
Why don't you
try to recapture what you said? Yes, well, I hadn't thought about it that way really, because I think, you know, the standard 4 with environment. No, yeah, standard 4. I think it is. Yes. In any case, if we produce or serve meals in our hospital that are based on production in Brazil. Not to say anything wrong about Brazil as a country, but that are produced somewhere across the world with a great destroying of natural resources, and then transported over to our country and sold for, I hear you say 12 euros, which is very cheap for a steak. or are they produced in the neighborhood somewhere in the local? And that is important on the whole way we think with health gain, etc. So that's more or less what I shortly pointed out. So
yeah, and I think Auli really started this discussion because she said that they started to look at the standards from a nutritional perspective, which I think is, again, as you are also said, you know, you pick one part that you can relate to and you work from there. And of course, nutrition is extremely important for the patients, for the recovery. They need their nutrients. Often patients might be in hospital because of wrong nutrition in the long term. So the hospital can perhaps have a role in impacting on that nutritional behavior and actually providing healthy nutrition. At the same time, we know that staff working in hospitals, and I'm only talking about hospitals here because it's distinct from primary care and other providers, staff in hospitals often have an unhealthy nutrition. You know, they have night shifts and take the chocolate bar from the machine, and you know, it's a well-established problem in research, nutrition, particular, not restricted to nursing stuff, but it impacts on the health of the employees. And so that was what Auli actually commented on. And I said then, well, actually, as Ralph said there, it goes further than the hospital has means of changing local procurement. And this is exactly the point that you made, Ralph. What does the hospital decide is being offered in the canteen? Where's the food being bought from? Is it all outsourced from a caterer? A lot of food is now outsourced, but do we actually want to know where the food is coming from? And I'm often shocked, and this is why I gave this example of the steak in the supermarket for 12 euros, for which the rainforest has been cut down. That's a beautiful connection, beautiful in a horrible context, but a beautiful connection on the relationship that food and nutrition in one setting has on climate, which is another key aspect that we're addressing in the standards. So I think there's a lot that we can read into the standards, that we can get from the standards, and therefore it's, I think, very important that everyone starts at the point where they feel most comfortable, because if we start with a whole picture, it becomes too big and unmanageable. But if we start with something like, let's walk through the nutrition and then think it all through. And the new standards have various statements about nutrition, not just what we provide in terms of nutrition advice to patients. It has standards on local procurement. It has standards on the display of food. It has standards on health literacy and food intake. So there are various things that really look at the broad vision that Margareta described this morning about health orientation. And I think this can be made very powerful then if we try to connect the different dots.
And it certainly addresses the difference that Margareta pointed out between productivity and effectiveness. Because if we buy the steak the way we were discussing, because it's cheaper and we will get a better economy, but it will not aid us in the health promotion, then it's a productivity issue and not an effectiveness issue, I think so. Okay, we have a few minutes if you want to, Bozina and Karin, something you would like to share with us, please?
Harald, not yet, because I have my remarks at the end of the
Okay, you're listening in. I'm sorry. So, great.
I will keep them
secretly hidden. Good.
Thank you.
Yes. Karin, you as the national coordinator in Germany, would you like to point out something?
Sorry, my internet was just frozen for a minute and I missed the conversation before. Are we still talking about what was discussed in the groups?
Yes, exactly. And yeah.
I think Helena touched on most of the conversation that we had. I had also asked about what type of tool would be useful for those who working in clinical settings. And the group discussed that maybe some type of online application would be a little bit easier to use, because there's so many standards and it might be difficult to see on a screen. But then again, to have that portability of an app is also useful. So maybe something, an online based application that also has an app would be advantageous.
Okay.
That was the only other topic that hasn't been touched on yet.
Yeah. Okay, I think that we have shared our thoughts with each other, and we are a little ahead of the schedule, but I don't think anyone would mind if you get a 20-minute break for the coffee. Is that okay? So I think we will reassembly at 10:15, and we have to stretch our legs and get some coffee. So see you soon. Thank you. Let's move on then, and we have now a 15-minute to discuss how we can use the HPH standards for continuous improvement. Do you want to start, Oliver?
Yeah. I just wonder, perhaps if I may, it might be better if we start with the points that you raised earlier today before we opened in the morning, and from there we can then look at the questions that I raised in my presentation. I think that might be a more logical flow. What do you think?
I think that too. I agree with you. So I will share with you some thoughts on this issue, how we can use them, and for continuous improvement. I just wonder here. Yeah. So, do you see my screen now?
Yes.
So I started with the issue, at what level, or maybe I should say levels in the healthcare system should we use the standards? And I think Eva gave a good example of using teams so we can assess the standards on different levels in our healthcare system. But when we've looked into this, we can discuss whether it should be used, for example, with Sweden here. This is the map of Sweden. On the national level, does Sweden have a healthcare system, a national healthcare system that actually is health promoting? Now, of course, this will be very difficult to assess the standards if we want to move forward and use them for continuous improvement, but it's still a question. Now, these different parts, you see with the lines in between, these are the 21 regions of Sweden. And they are divided into 6 healthcare regions, but we have 21 regions, so we could think about it as the regional level. So that is one way of using them. How are we doing in the region where I live, which is right here, Västra Götaland? We could also look at the hospital. These are the hospitals we have in Sweden. And so we can look into the hospitals. I haven't pointed out, or I haven't pinpointed the primary care centers, because they are a few thousand, at least in Sweden. But so should we look at it on the hospital level, or should we look at it on the clinical level? These are whether it is in the primary care or in the hospital care. And what I've noted is that if we want to assess the health promoting, where we are as a health promoting organization, and this is, of course, I understand this is a little, it's an estimation, it's not exact, but it's fairly easy for a team on the national or regional, preferably regional level, to assess the standard one with the goals and policies, etc. It's more difficult to assess the standards 2, 3, and 4, because who are we going to ask? That's an important question, whether we are working person-centered, whether we're giving the patient enough time to be well informed and to be part of the decision-making. I think only the patient can answer that correctly for our setting. So there, it's more difficult to assess on the national level or regional level. If we go down to the hospital level or primary care level, it's fairly easy to, it's easier to assess also other standards like 2 and 4. You have access to the staff, you can discuss with them, you can form teams. It's more difficult to assess the standard 3, the person-centered and the interaction with the patient. And finally, if we go to the clinical level, standard 3 and 4 should be fairly easy to assess, whether while the standards 1, 2, and 5 are more difficult to assess. So that's actually more my thoughts about this, and how can we then use the standards to improve. And I think that the other question here is, how do we take care of the results from the assessments? I think Oliver and I know Oliver and I agree on the point that this is a tool for self-evaluation, not for comparison or with other organizations, but where are we, where do we assess ourselves today? What are we doing to become better? And then we make a new assessment. So quality improvement and self-evaluation are important issues. I think that showing the results in a graphic way is very, it's important, not just figures. It's important to show, well, here are our weaknesses. Here we are very strong. We don't need to put more effort in there. And also, it should be, if not mandatory, but at least it's important to, from the results, create an action plan. And the tool can actually help us to find the areas or the standards where we are not performing so well, and give us the basic of an action plan. And finally, we've discussed in Sweden anyway, the interesting to review each other. If my organization makes a self-assessment and we find out this is how we are standing, another organization, hospital or region is doing the same. And then if we can meet and we can discuss our results, not to compare, but to say, oh, you assessed it this way. What did you do to get that far in that area? And we could share knowledge between our organizations. So those are my thoughts on this, how we can use the result, how we can use the standards and take care of the results. Okay, Oliver. Yeah, this is, this is just a way of showing how the graph can show us. Here we have an area in this that we are not so good at. So this is where we should put some effort to become better. And then we can use it for an action plan. So, okay, I'll leave it to you then, Oliver. The microphone, I think you need to put on.
Oh, I didn't click well enough. Okay. No, thanks for this overview. It's great to see how you thought through the different uses, and we had a brief exchange before we started the seminar this morning, and I think we agree. That's very good, because you didn't say this is now the basis for an external assessment, an external evaluation, or some form of punishment if you don't reach a certain standard.
Or competition.
Yeah, which we know is dysfunctional, that wouldn't work. So the whole idea of the document, and not just a document, you know, the whole idea of the network is about empowerment. And we want, through this tool, empower users at different levels to engage and to operationalize the health promoting hospital vision. Because we know that the vision itself, while we intuitively agree to be right and good, it's very difficult to operationalize it. And this is why we need the standards. I would very much like to hear also from colleagues in other countries and what they think about the ideas that you suggested. Let's say in Denmark and Poland, to see whether that also reflects on, or that their views reflect also the approaches that has been suggested for Sweden. On the note of who can assess a certain level of standards, you raised also a couple of really good questions about the role of patients and professionals in actually rating standard compliance or achievement. In the past, these documents have been used mostly by a small group of professionals sitting with the self-assessment tool around the table and discussing, do we do this, do we do that? Yeah, here, partly, yes, no. And this is linked to the idea that I suggested with the app, because I think once we have the standards in an app, it would be easy for, again, as an example, a hospital to say, on Monday, everyone is encouraged to, rate how we're doing on these standards. And then you might get not just 5 people sitting on the table, and these 5 people being the ones that discuss these issues all the time, and they might have preconceived ideas already and their own biases. You might get everyone on the wards involved and say, well, are we doing this? Are we not doing this? And you get perhaps a response rate of 500 people saying, well, based on our rating last week, we did well on this, but we didn't do well on that. That might generate much more power actually to bring it to management and say, well, we need to do something. So that's what I take from your questions about who can actually fill these standards. And then if we even take it further, you mentioned the patients as well. Now, some of the standards might, in fact, require asking patients in the end. If we are asking the question, does the healthcare service provide sufficient support for patients to engage in their self-management after discharge? Yeah, you see the issue, right? We can ask the professionals what they think, what they're doing, but ultimately that would require the type of measures that Margareta referred to earlier. It might require proms and prems. Yeah. So the question is then, what role, what responsibility does the health service admit to implement the measurement of prems and proms? And how are these measures being used? I know that in many countries, some form of prem measurement is mandatory. Some countries have some form of prom measurement mandatory. And I've done some research on that as well. But the question when I ask always in the health service, clinicians and managers, how do you use this data? It's not encouraging to frame it politely, because often this data is in a report, in a drawer somewhere, but it's not really used for improvement in the departments at the front line. So I think, again, that is I can't pronounce that word. Can write it, but I can't pronounce it. Some words in English I simply can't pronounce. Kevin, you need to give me some lessons. Anyway, it's an implication for the standards that we think through what kind of level of measurement is required and who actually collects this data and what are we going to do with that. And that reiterates again the point that it's not a tick box exercise. Like if you've got a yes, it's not completed. No, we need to use that information to further improve. And I think the only way to do that is to include a broader and broader number of people in the assessment and in the implementation of the standards. It can't be delegated to one working group for an organization that has 2,000 employees and 30,000 patients a year. I'm stopping here. I've got some other things to say, but I'm just making a pause here because I would like others also to be able to respond.
Yes, we have time for some comments before you go on, and then we have in our agenda time for another group discussion for a few, so we can discuss this more. But go, please, Margareta.
I just wanted to comment on your important what you said, Oliver, because I think one of the problems with traditional way of quality work and reporting is that it is a top-down activity where reports go to the management and it becomes a load instead of a learning possibility. And if the standards are used and applied to make possible for people at the different places they are working to actually have a method to see how they perform and do that again and again. We want to be better. We want to learn, and if this is applied as a learning system, it can be very, very good. And actually, the easy about I've been working with prompts in national quality registers in Sweden, and they are actually mandatory to have the funding at accreditation at second level. And what happens is that many of them ask patients to report to questionnaires where responses are never used, and that is unethical. It's not acceptable. But if you use it, you can learn a lot.
Thank you. Do you wish to continue with some further comments before we go into a group discussion, or do you want more comments from the? Because I have posed a few questions that I would like to send with you to the group discussion, and those are actually addressing who should be part of the assessment team, how do we involve patients, co-workers, and population, how can we measure, and how should we use the results? Now, I don't expect us to have the answers to all of these questions, because that is actually what Oliver and the rest of us are working with, but it would be interesting to have that discussion. But do you wish to add something to that, Oliver?
Yeah, I'd just like to show one slide one more
Great.
time. And let's see if I can find the right. Do you see that slide?
Yes.
Yeah. So I went through these different points earlier in my presentation, but perhaps for the groups, it would be very nice to have a discussion also on functionalities of an app or web platform. If we were to develop it, what kind of input, what kind of information would you like to have? What kind of functionalities should that have? And how could that support the measurement that you just referred to, Ralph? Because now if we had an app, as I said, and you know, that would allow every professional in a hospital, provided that function has been released and supported by management, it could allow any professional to rate how the hospital is doing in terms of standard implementation. And that might be more informative of having an expert panel sitting together twice a year and putting tick boxes on a sheet of paper. Because, you know, sometimes those experts are not doing the work on the ward anymore. So, you know, that's a measurement issue as well. But again, if you have any ideas about functionalities that could be developed or that could be built into such an app, please let us know, and that could be some of the discussion points as well.
Yeah, I put that in the chat. So when you go out into the discussion groups, you will be able to open the chat and you will see the now five questions. And of course, you can decide which of these questions you want to address. But remember that this is all the aim of this group discussion is to help us, including Oliver, etc., to develop this tool, whether it's an app or whatever it is, because it's a continuous improvement. So if you're all right with that, we go into a group discussion for about 20 minutes, 20 minutes. Yeah, I think that will be sufficient. And I think you will find that you are now in new groups, more or less.
Ralph?
Yep.
I'm an old lady with short memory. Could you maybe repeat the questions, because you
Yes.
had rather many?
Yes, but if you open the chat, you see down there's the chat.
Good.
I realize that nobody will remember what I say. So I put it in the chat, and you have 5 questions there,
You
and then
are
they
so
will
elegant. Thank you.
go along with you into the discussion groups. Okay.
Very good. Thank
Any
you.
other questions?
No.
No. Go. Great. Shall we start with the hourly group together with Margareta and Oliver? I'm sure you had some interesting discussions, hourly. Would you like to?
Yes, of course, it had very interesting, and I can give Oliver perhaps can tell about.
Oh, thank you for volunteering me. I'm happy to do that. I think we started discussing the use of the standards and who's measuring, who's being involved, and Auli gave some examples from her experience and how this could be done. I think there was a general agreement in our small group that it would be beneficial to involve a larger group in the assessment and implementation of the standards. And if we could reach out to a larger group through assessments, then I think that could be very powerful. The second point that we discussed is that Auli also mentioned that for clinical professionals on the ground, they really need to have something very practical, less theory or concepts. It needs to be practical. And to support the practical approach, it would be really great if we were able to link to some models of good practice, because that would be very encouraging for professionals to see has been done somewhere else. There has been some results. There might be an abstract. There might be a document or video or whatever resource. And that would make it then much more operational. That was the overarching question we had this morning, how to operationalize this. Would it make it more easy to operationalize steps towards actually implementing something that is in relation to the standards, but which could be informed by a model of good practice or a local adaptation project in another country? And the third point that we just discussed now at the end was on the roles of prem and proms, particular proms. And Margareta shared some experience on the use of proms in the registries in Sweden. I've learned there are more than 100 registries and different levels of certification. And at level 2, if I understood correctly, you need to have included proms. At level 1, you need to demonstrate that they're being used. So perhaps in Sweden, it would be very interesting to see how the standards relate to the registries and how the registries can actually support the implementation of the standards, because some of them might have already collected prompts. So there's no need to collect it again, because the registries, I assume, from what I've read about registries in Sweden, they're professionally set up organizations that collect data nationwide. I've seen papers in good clinical journals describing the results of these registries. It would be nonsense to try to duplicate this effort. So we should really build on that and see how those registries that have included prompts can support the implementation of these standards. Not sure if Auli or Margareta want to add anything.
No, I think you made it good, and we also discussed about the inspiration of learning, how the pride in the group when they actually talked about the smoke-free hospitals questionnaire, which, if you remember, Helena, and with us in Sweden, when it came first, we were a bit skeptic, and we felt it was very long, etc. But I can see that when people have read the results and can see that they perform well, it gives a very big pride, and an important feedback to the directors to say, well, we are actually rather good here, and we shall take care of that, I think.
Okay. When we discussed the issue of who should be part of the assessment and how do we measure, etc., with prems and proms, I think, Karin, you said it very well. How can we not involve everyone? I think it was you who said that. I don't want to take your words, but if you want to say something about that from the group discussion.
Sure. Yeah, so I posed more of a question. When we look at the health promotion approach, the whole essence of the settings approach to health promotion is that we involve everybody who comes in contact with the setting. And so in response to who should be involved in the assessment team, I asked, well, how can we not involve everyone in the setting if we're going to truly assess if the setting is health promoting?
Right.
And the teams should be interdisciplinary and diverse. If you only include a certain group of people, you're not truly going to assess if the standard's being implemented because you only have the opinion of one group.
Beautiful. Hans, you made a thumbs up. Please comment.
Unmute. Well, I agree. And it should be including also the directors, the regional directors. In our group, I said, I have a dream. And that would be to have a setting with diverse group, as you said, Karin, and also the health, the one in charge for the region, to sit down. And I told my group about the reform, the Swedish reform that is now supposed to be set in practice, the good and close care, where more important, and you also bring the hospital facilities that don't need to be there out further or closer to the people. And the main theme is health promoting, and what the regions now are fighting in our country is the demographic change, where we will have 20-30% more that are getting sick and need the healthcare, and we can't afford it. But we also know that we can prevent 30, 40, 50% of this if we are more health promoting. So start out now a base setting, use those tools with the international standards and see where are we, a base standard, and we have to bring all kinds of people into that, and then we have this to see how far are we in 1 year, 2 years. So we're at the starting point.
Good, thank you. Anyone else want to comment? We had a very interesting discussion in our group, but I think let's see. You have the Oliver group. I can just lift the teams discussion that Eva started in our group, and if I connect that with Karin's point about everyone needs to be involved to make this possible. If we have an app or what, we could form different teams, and they answer the questions or the standards that they feel relevant for their position. And then we bring them all together in one. Oh, that is my dog, I'm sorry. That's the way it is. They are great when they sleep, just like children. In any case, and then we bring them together and we get a final result. But also that is, of course, a huge challenge, because we don't have co-workers that sit on their butts and don't have anything to do and just waiting for us to send out this tool and ask them to answer their parts. So should we say something about your question, Oliver, the functionality? We got something from our group anyway. None had inputs on the functionality. Do you want me to relate to that? I can tell you. Or do you want to say it yourself now? I can tell you. As I understood it, the functionality, an important part of it is to be able to get the answers straight into the database, not through a paper sheet, not needing to put down on a questionnaire and then take the questionnaire and put it in. But we need to, if we involve or when we involve patients, co-workers, administrators, directors, they should answer straight into a common database, and we can use the results together. That's one of the functionalities. And then we also discussed the way we have thought in Sweden about working. And Karin asked me to show you, I think you've seen it already, Oliver, but just for a few minutes, the possibility to see the results fairly straight away. So I will show you a little of our thinking, right or wrong. If we take any standard here, we have put a help, we have posed questions. Now you can't understand this because it's in Swedish, but in every standard we have put a question or a definition on what does it mean, and what question should you ask yourself in order to assess this. For example, our organization has methods to assess and document the need of intervention concerning risk factors such as tobacco, alcohol, food, and nutrition, and physical inactivity. So we have posed questions like, describe what methods we actually are using, instead of just saying, yes, we have, or no, we do not. And we have questions like, what data are you actually collecting in order to assess this? And that is to make the ones assessing to start thinking and not just saying, yeah, I think we have that. So we have that on all of these. And then we have, as you know, Oliver, we have decided to not to have a scale where we do not say yes or no, but we evaluate to what extent do we have these methods, etc. And finally, we also have the possibility to exclude methods or standards that we do not think are relevant, and we can put them as non-applicable, and they will be grayed out, or we can put them back on if we want to, so like that. Finally, what we do is we show the results from the different standards, 1, 2, 3, 4, 5, with these kinds of graphs, so that we can see where we fail or are not as good, and where we should not put in more efforts. And any standard that is on the figure 3 or less, or like these, are put into an action plan. So here we have these 6 parts that we are having an action plan where we can put goals for that standard, what factors influence that standard, what activities should we take in order to become better, etc. And you can copy that out. So that's a little of the functionality, at least that I would like to send in. And of course, you will have this if you want to look at it closer. I'm not finished with translating it back to English yet, but maybe we will do that. Okay. So, anyone else from the groups? Otherwise, we'll move on in our.
We had the same discussion as we did before in the first group, which was if we would prefer an application or web-based. And I think that we concluded that we prefer to have a web-based. Also because it would be easier to share with decision makers and also to show graphs and etc. as you just showed us, Ralph, to actually use them so that what we put in the system is usable afterwards. So it's not only collecting data, but also using the data.
Great. So you
and actually Hans raised the question about GDPR as well, and if that is more of a problem if you have an app. I'm not sure about this because I'm not really I don't know very much about it, so I'm not sure how that is applicable, but anyway. Hans, you might know more.
I don't think that GDPR is relevant here because we don't collect personal information. You don't have any.
No, it could be about. No, it's not. It's about certain. It's not only the regions, but it's also private companies and so and their data. I'm not sure. I don't know this, but maybe one should have at least a look.
Oliver, have you discussed that issue?
No, not in detail. It's just the questions that I raised earlier about privacy, that it needs to be clearly said who has access to what level of information and who can enter what information and who else can then review that information.
Exactly.
Because you don't want that, say, a doctor on the ward rates an implementation of the standard as poor and then gets the head chopped off by the manager who disagrees with it. So there needs to be privacy about this kind of assessment.
That's right. That's right. Okay, dear friends, we have now reached the summary reflections, and now, Bozina, you have collected lots of information and thoughts, and we are eager to hear your reflections on what we have talked today. So please.
Unmute, yes. First of all, thank you very much for organizing this seminar, which is very engaging, you know, mentally engaging in not only creating, because the standards are already prepared, but to implement them, to understand them better in order to then to transfer the knowledge on the national and regional level. So I understand the standards as a kind of directives, guidelines, where to focus, because as you said, that not every standard is applicable in every organization. But this is, we have to use, I wouldn't say it's, we have to use our brains to take the best of the standard and to implement, and of course, if possible, then to develop possibilities to implement every standard listed. And of course, as I said, there are different settings, different levels of assessment and different facilities, and it's really only self-evaluation, as it is difficult to compare the different organizations, because there are different hospitals in different areas. First of all, I would like to congratulate to the Swedish friends what you prepared as the self-evaluation sheet. It's something that I have never seen. I mean, as a tool, and I really hope that we can implement it in other countries as well, because this is absolutely wonderful. And this is good that you have to answer the question not yes or no, because it depends on your mood. You can think differently, but then to the extent of achievement, this is absolutely great. What I would like to say about the Polish system, we are not really healthcare oriented. I mean, generally, this is what I see when I discuss with the Minister of Health. Of course, they do have the department. They not the heads telling that they understand the need, but this is the end of the story. When you go to the hospital managers, you see different attitude. I have to say that when we see our budget, country budget on the healthcare system, 97% of expenditure is the reparative medicine. And it's mostly non-communicable diseases, where only 3% we use for health promotion. So this is absurd, but this is how it is. So we have a really challenge to work on the national and regional level. The pandemics has been a kind of excuse, that's first. So we don't do anything. We concentrate on pandemics and on the sustainability of the system, healthcare system. However, now we more and more our politicians say about the consequences of pandemics, which are of course psychological issue as post-traumatic stress disorders, psychiatric issue, of course, obesity, alcohol overuse, and sedentary lifestyle, as the home office is everywhere. And this is something our government sees as the problem. More else, I would like to say that our organization needs to be a help to coordinators, not on the national level, because of course we understand much more what's going on in the organization, but then it's our role to help coordinator, and the language barrier is something that I would like to raise. Of course, we will have the translation, but again, we have to find resources to do this. And I would like, yes, healthcare workers should be helped to implement the standards, because they may not, there is nothing in our curriculum on that. I mean, health promotion generally in medical university is not the first line what we educate medical students. Mostly it is well, the nurses finally they do have health promotion, but again I would add to the curriculum this motivational intervention and communication with patients, because we do not have this as the obligatory item in the curriculum. And our system is constructed in a way, because we discussed about the primary care role in the health promotion. And our system is constructed, unfortunately, in a way that the incentives or the way of payment does not include the health promotion. And the most primary health facilities are private. Of course, it's a private and public because they are private financed by the public money, but still the system of payment is not in favor of health promotion. So this is, but it's good that our politicians now, they see the need to change it somehow in order to provide the patients with the health promotion, or I mean the education, let's say, not promotion, the health education at the very basic level, at the primary healthcare. So this is, yes, as proms and prems, they are not very well known. Definitely not in public system. They will, however, again, we do not have yet the quality system evaluating the hospitals or any kind of health services. But again, they are noticed now by government, and I hope that they will be soon prepared and implemented in healthcare facilities. I think this is, this is all from Poland. So we have a difficult time, and we have to change the mentality of policymakers towards the health promotion and health education. Thank you.
Thank you so much, Rosina, for your reflections, both on this seminar, but also on the system in Poland, because it raises my awareness of how different the settings are for our different countries. And that is, of course, a challenge for the HPH organization to create standards that are applicable, and also a procedure that is applicable in all over the world. So we have to be humble that not all have the same settings. Thank you very, very much. We said when we planned this that also you, Nan, would give us some reflections from the day. And then I don't know if you know Kirin Waiheli, if she has had some, she hasn't joined or she hasn't been with us, but if someone, Auli or Juha wants to, or Eva wants to comment from the Finland, you're most welcome. But please, Nan, give us your thoughts over the day.
Thank you very much for very fine presentations and discussions all this morning. And I also have some thoughts from our last meeting where we arranged this seminar. I think the standards are umbrella standards. And I think we need to work with the standards locally in each country and in each institution to define what are the content and what are the essence of the standard, to operationalize it for use in clinical practice. And my thought is that we should always have the user, have the patient in focus. What use is this standard for the patient, for the core action in our service, for the core, and thinking a little about also the measurable elements, I think is useful to sort of translate the standard to the local use. But I think we have this umbrella now and we can pick from it. And I think it's important that we pick elements that we can use, well, today or tomorrow to start a process. And as many have said today, that we have to involve, well, almost everybody in our daily clinical practice to know and to walk forward towards our standards, to know the standards and to fulfill the standards as well as we can. If we only have one or two quality improvement persons in the organization, it's too vulnerable. I think we need to expand it. Quality is everybody working with patients, and also myself and others today mentioned that the proactive thought in our standards is also important in our local community. We need to involve our local communities in knowing these standards and working towards these standards. And how we do that, I don't know. But I think if we talk about the standards, present the standards, show the standards, maybe my thought was to contact the Danish, the patient organizations we have in Denmark, and tell them, well, we have this set of standards, umbrella standards. How do you see we could use these for the purpose of the patients? And these patient organizations are well, it's psychiatric patients, it's pain patients, it's arthritis patients, and so on. So it is patients with chronic illnesses and with I think it's vulnerable patients, many of them. So it could be also a way to go to involve these patients' organizations. That was a thought I had today from our discussions.
Thank you very, very much, Nan. Very interesting and very, very important thoughts. Does anyone from the from Finland want to give some conclusions, reflections over the day and what you've heard and learned, maybe?
Maybe I would like some couple words. We have a same kind of social and healthcare reform going on here in Finland as our neighbor in Sweden, and I think we have to translate one more time these standards to different kinds of target groups and open them more. And I was very relieved by the words of Oliver's when he told us we don't have to make an action plan for all of those standards, and so we can pick up some most important ones in different kinds of parts of Finland, also in different kinds of organizations. And in addition to that, we are very eager to make a follow-up or measurements project, as you, Ralph, showed what you have done already there. And I think next autumn will be a very important time to implementing those standards and use them for the development of HPH in different kinds of organizations of our HPH network here in Finland. So that's some words to put in short. Thank you.
Thank you, Juha. And that sounds great to hear that you're on the move, like some of the rest of us. So interesting. Now, it's not in the program, but I think, Oliver, that I would like you to also reflect a little on this. You have the possibility, if you want to, in that case. You've heard a lot today, and I think it's been a great day, but it's what you think that is important.
No, sure. And first, thanks for the opportunity to participate in these discussions and contribute to them. I think even though the group is small, I think the discussions were very rich. and the format really helped. You know, having a mixture between plenary and the group work, I think that was really, really good to, you know, get to know each other a little bit better and discuss in smaller groups. So that was really good. Other than that, I really take from this discussion that in general, we seem to be on a good track in the overall network with the development of these tools. It seems that as it was the case 10, 15 years ago with the first set of standards, it really ignites a new level of discussion because it becomes more concrete, and it yet has to become even more concrete to be practical. But I think we're on a good way. And if we can maintain this momentum, and maybe in a couple of months from now, whenever late autumn or in spring, we'll come together. By then we will have a new level of discussion, because then we will have the measurable elements, we will have further translations, we will have advanced our work on developing tools as a web or whatever platform. I think we're really on a good track yet. And yes, key for me is to bring down this discussion to those that are actually doing the work, because that's often what I realize when we are working at the International Secretariat. Of course, we have great working groups, we have the General Assembly, we've got the Governance Board, and these discussions are all very important from a strategic perspective. But I always think, do we reach the people that we should reach through these activities? And I think that should be the guiding principle. And if in a year from now, there will be 10 times as many people in those health services in some way working on the standards, looking at nutrition, looking at smoke cessation, looking whatever the focus is, then I think we're really on a good track to working towards a reorientation. And I've said it in the first working group, I think there are still really big challenges ahead of us in terms of addressing not just the reorientation of the health system, but, you know, the One Health concept, you know, the human, the animal, the environment, environmental health issues and how they are interlinked. I think these discussions are becoming more and more commonplace. We shouldn't overwhelm people working 12 hours a day in patient care with diffuse concepts that are not practical yet. But at the same time, we need to continue developing those themes, because I believe they're very important, not just for the health of the patient and the community, but, you know, for global health and for global health, full stop.
Thanks, Oliver. Thank you. And thank you very, very much for participating. Now I will leave it to you, Margareta, to conclude the day, as said in the program. So please.
It's a challenge to give all these interesting discussion a proper collection, but I do agree with Oliver that I think with the help of this new standard, we have a new level of discussion, which is very interesting. And I think it's when you have concrete things on place, you can have a better discussion. Again, to none, the patient focus is that is essential. And to me, health orientation in terms of if patients and people are healthier or helped by what we are doing, that is the sense of what we shall do. And I think it's also so that if we can make this work so that people working on wards and different places can help an instrument to see if they perform better and to do what they actually want, namely give better health to the patients, people will have a better working environment, because everybody wants to do their best. But if their manager asks them to have as high productivity as possible, which is often the case, then you have a big frustration, which we have today. But if we all agree that we are here to do the best for every patient, and that is actually the most economic way to work, then we can have a work environment for health professionals which is much better, where people are having a learning climate and a professional pride back again, which has been somewhat lost in this sort of most structured way of working. I believe it's very important that we have the umbrella concept, that we have this holistic description of the concept, because the very point of the HPH concept is that it is reorientation. It is about the whole system. But again, everybody cannot do everything. So that for every people, all who are working, for some it's the psychiatric ward who's in the center. For some others, it's the environment. And some are deciding what kind of food shall be purchased for the kitchen. And thus, some of the standards have different practical applicability for people, but people in the top management, they need the full breadth of it to see what this is about. And knowing our directors, this is what people want. And we actually have, as our Swedish colleagues know, a very ambitious system of knowledge-based government for an equal and good health in Sweden. It has some tiny problems in tending to be very disease-oriented and not always a holistic health approach, and not always being proactive prevention-oriented. But if we can link these instruments to that, we do have a very big possibility. And not least, again, back to now that we need to take the step forward now from individuals and patients within the health service to open the doors and really get out to have contacts with the local communities. And also here, with the help of the standards, we can help people to see what do you mean with that? What concrete should we do? And the standards are helping to be more instrumental in that. And I think that is very important. And last but not least, I would hope that these standards can help us going from an economy geared health service to health oriented health service also in management issues, so that I know that we have restricted money, but the money is the means, and so that the money becomes the means, and the quality, the health outcome, the aim, and so that we in our yearly accounts and discussions, the funding is one little part, and the main part is what is the outcome for the patients, and what's the plan for the future to have improvement on this. I think that will be more effective and a much more inspiring way of discussions between people at the board and people in the management. So tools for inspiration and learning, and also governments. That's good. Thank you.
Thank you, Margareta. That's a vision that we all can share, that the result is the result for the patient. So, dear friends, I think we've reached the end of today, or not the end, or the beginning of the end, but maybe the end of the beginning, or whatever he said. And it's been great hosting this seminar. It's been, even though we've been a rather small congregation, it's the quality and not the quantity that is counting. And I have, as you have seen, recorded this session, and if it's okay, I will put it, I will send it to you one way or another. Maybe we can discuss that, Karen, if you want to have it available on the HPH website, or, well, we can discuss that, but you, the participants, will get access to it and the material. And also, I hope that this is not the last Baltic seminar that we arrange. I think this way of arranging is very intimate in the way that we actually can go a little deeper, like Oliver said, small groups, but very intensive and engaging discussions. So I pass the stick on to either Denmark or Poland, because we've been now to Finland and we've been to Sweden, but it's not a competition. I just hope that we can continue to meet in this way. And then also, of course, a special thank you to Oliver and Karen for participating. Well, Karen, perhaps as the coordinator, you from Germany, you are also close to the Baltic Sea, aren't you? So maybe you want the stick next time, but I guess you're here also because of your role in the secretariat, and you helped us to arrange this. So a special thank you to all of you. And by that, I just think we can wish each other a very happy holiday, or great holiday and nice weather. Is that okay? Thank you very, very much, all of you. And take care of yourself. Keep healthy.
And thanks for moderating the day.
Thank you. Bye-bye.
Bye-bye, everybody.
Bye.
Bye. Bye-bye. Thank you.